Okay, the third in this trifecta will cover fetal CNS and skeletal dysplasia, and then you'll know everything. I just want to reference the guidelines for performing OB ultrasound exams and highlight the parts that are specifically mentioned in reference to fetal CNS. Biometry, of course, includes BPD and head circumference. The spine, we're specifically instructed to document cervical, thoracic, lumbar, and sacral in sagittal and transverse views, and the ventricle. And then in yellow are some more detailed terminology that's been incorporated into newer iterations of the guidelines: the lateral cerebral ventricles, the choroid, the posterior fossa, including cerebellum and cisterna, the cavum, the falx, and most recently, the upper lip. So, of course, every time the guidelines come out, nothing goes away, but more things are added, including CNS-related anatomy. The anomalies we're going to cover in this session are listed here, primarily focusing on ventriculomegaly because it is such a crucial observation in detecting a whole host of CNS abnormalities. Scott, it hasn't kicked in yet. You can turn me on. Okay. Fetal cerebral ventricle it's required observation and a useful observation in every obstetric sonogram, even, I would tell you, in follow-ups for growth, because ventricles can change, and if they become dilated, you want to know and think about why. When we see fetal ventriculomegaly, there's a guarded diagnosis. We want to think about the cause of the dilated ventricles, and in particular, a recurring theme in this talk are other abnormalities besides the dilated vents. Those will inform prognosis. It's expected ventriculomegaly will be detected. Once detected, a measurement is used. Again, like I said, with fluid assessment, trust your eyes, trust your subjective assessment. You've seen a lot of obstetrical sonograms. If it looks normal, it probably is, and if it looks abnormal, pursue it, chase it, and measure it. One of the clues in that subjective assessment is, does the choroid fill the lateral ventricle? And on your left is a case where it fills. We don't need to directly measure it. We don't routinely measure normal-sized ventricles in our lab, but if the choroid appears to be dangling, if you will, not filling the atrium of the lateral ventricle, that will catch your eyes and prompt you to measure it. On your left, a measurement is placed on that choroid-filled ventricle. It's normal, typically between 6 and 8 millimeters. On your right, one is measured because the choroid doesn't fill. And we use that subjective assessment to prompt a measurement, but in this case, the ventricle measures 8 millimeters, still a normal-sized ventricle. What's abnormal? Over 10 millimeters. It's a well-established threshold value, been in the literature a long time, a very reliable number. We trigger a workup for ventricles that measure over 10, and usefully, helpfully, that number applies throughout gestation. Now, all of these pictures I'm showing you document the measurement of the dependent lateral ventricle, and I would say if there is dilatation, in addition to the number, I'd comment whether it's right or left. We don't routinely see the upside ventricle. We can take some maneuvers to get a glimpse at it, but we can't see it in a reliable way to measure it. And the guideline is assume symmetry unless otherwise shown. And sometimes it happens that a fetus turns from one decubitus position to the other during the exam, and you get a chance to directly see both ventricles. Now, why is this so important? Because ventriculomegaly is often the sentinel observation. There is a long list of really significant abnormalities shown here associated with ventriculomegaly, and for many of these, the dilated ventricle will be the most obvious first indication. It really is a tip of the iceberg observation. The cause of that dilated ventricle, which you might find by pursuing the exam, targeting a survey, the presence of other anomalies are really important, and the degree of ventriculomegaly is a less crucial observation, though something to address. I'm going to start with a discussion of marked ventriculomegaly. This, of course, no one would miss. For most people, marked refers to diameters greater than 20 millimeters. It will be important to consider how big the head is, because at time of delivery, macrocephaly may be a factor in the consideration of candidacy for a vaginal delivery. The differential for such marked dilatation includes hydranencephaly, which is Basically, the sequelae of cortical destruction, brain formed but was injured, usually from a vascular event, holoprosencephaly, which we'll discuss, and aqueductal stenosis, which really is a diagnosis of exclusion when you can't make other observations to explain away the dilated ventricles. So the documentation of the midline falx, which is now a required image, is helpful in this regard. In holoprosencephaly, the ventricles are fused and there is no midline falx. This is the sequelae of failed cleavage of the prosencephalon, and you'll remember there are 3 subtypes. I don't think that's the most important thing to address, but to recognize a form of holoprosencephaly, and one of the most helpful observations you can make to recognize this condition is the fused thalami. Here's a path specimen and a sonographic correlate of that observation. It really looks like a fist of tissue partially surrounded by a single monoventricle. This case on your left clearly has intracranial CNS abnormality, but might be hard to sort out, and the suggestion is sort of a step-by-step. Once seen, the fused thalami can be sort of recognizable, then realize we're dealing with holoprosencephaly. There's confluent anterior cortex, no midline falx, a dorsal cyst separated by the hippocampal ridge. You've probably heard the phrase, the face predicts the brain. Not every case of holoprosencephaly has an abnormal face, but upper lip is now a required image. Images of the face with certain features would lead you to expect intracranial anatomies. What are those facial observations that predict brain abnormalities? A midline cleft lip and palate shown here, an unusual nose with a single nostril, a sebocephaly. And we often get, as part of our routine exams, images through the fetal orbits showing the globes, a normal separation. There are nomograms, but subjectively, there should be room for a third eyeball between the other 2, and if they're too closely spaced, in this case touching, you can diagnose hypotelarism. And there are even more profound abnormalities that can be seen, cyclopia with a single globe and ethmocephaly. These dramatically abnormal observations have a high association with chromosomal abnormalities and, in particular, with trisomy 13. Leaving the markedly dilated ventricles and focusing on what we see much more commonly, which is moderate or mildly dilated vents in the 10 to 20 millimeter range. There's a differential here, including myelomeningocele, Dandy Walker, and agenesis of the corpus callosum, which we will address. Chromosomal abnormalities are also on this list, and typically when dilated ventricles are seen, amniocentesis is offered. In this case, we can see the choroid doesn't fill the ventricle on your left, prompting an additional targeted view, finding these periventricular calcifications, and suggesting an additional workup likely due to torch and in utero infection. When dilated ventricles are seen, the posterior fossa is a helpful next step in the evaluation. This is a normal cerebellum with views through the posterior fossa, and here 2 side-by-side cases of abnormalities, which we'll discuss further. We don't routinely measure the cisterna magna, but if you were to do so, normal is 3 to 10 millimeters, typically on an axial view. Sometimes it can be seen on a coronal plane of section. In this case, the cisterna is effaced and the morphology of the cerebellar hemispheres is altered. This has been referred to as the banana sign. I think it's okay for you to use that in your brain, but not in your dictation. The banana sign is really a manifestation of that effacement and alteration and lack of normal convexity of the cerebellar hemispheres. There are degrees of effacement, but recognize that if you do not see the cisterna magna, you're appropriately thinking about a Chiari malformation. An additional observation you might make transiently typically is bifrontal concavity, which has been referred to also as the lemon sign. I think these nickname signs, again, should make you look for those features and then describe them medically. What we are observing are the sequelae of a Chiari-2 malformation, and once having made that observation, we're going to go looking and basically not hang up the transducer till we find the highly suspected distal spine abnormality, the myelomeningocele, with which Chiari-2 malformations are so strongly associated. So the first clue is the sequence. See the ventricle is dilated. Look at the posterior fossa. See that it's abnormal. The myelomeningocele might be quite obvious with a big sac on your left, or quite subtle with the smaller sac on your right, but your index of suspicion is appropriately high because of the intracranial abnormalities. Risk of myelomeningocele about 1 in 1,000. The lumbosacral location most common. Once seen, we report the level of that lesion because it's associated with prognosis and, frankly, with patients' candidacy for potential intervention. Sometimes the first pickup is the elevation of maternal serum and amniotic fluid AFP levels, but I'll tell you, it was in the news last week. The rules are changing in prenatal detection of chromosome abnormalities and how AFP is going to be used in the future now that there's cell-free DNA picking up chromosomal abnormalities in maternal blood. We don't know what the future holds about how reliable, how widely AFP tests will still be used, and our ability together to diagnose these in utero. Historically, the serum AFP screening test detected 80 to 85%, and with ultrasound looking at these observations, aware of these clues, the detection rate's over 95%. That clue being ventricles and posterior fossa. And I just want to make quick mention of the results of a randomized trial for fetal intervention for myelomeningocele, diagnosed in utero by ultrasound. Patients in whom isolated myelomeningocele were found were randomized to in utero or postnatal surgical repair. And a quick recap of the findings. Prenatal surgery compared to postnatal surgery had decreased rates of VP shunting, improved mental development and motor function expected for their level, and improvement in that Chiari-2 malformation. So there is an incremental improvement in outcome. The downside, as you can imagine, is an increased risk of preterm birth and uterine risk to mom because it involves maternal surgery, uterine hysterotomy, and here's an example of a uterus cut open and a fetal myelomeningocele exposed. But patients currently in America who are candidates based on inclusion criteria are offered that intervention. Now back to mild ventriculomegaly, and by this I'm referring to ventricles measuring 10 to 15 millimeters. Remember that many of these are normal variants, but in the mix are other structural abnormalities, sometimes obstructive hydrocephalus or other subtle CNS pathologies. It is more common and less concerning in male fetuses, and the outcomes in girls or boys is better when isolated, like everything else. We look very, very carefully when we see mild ventriculomegaly for other CNS or non-CNS abnormalities. Here's the guideline of how we evaluate and counsel a patient in whom mild ventriculomegaly is seen. She is offered a targeted or level 2 survey looking for other abnormalities and, frankly, for gender. Careful family history. Amniocentesis is offered to include karyotype and viral studies. And I will tell you that at UCSF, mild ventriculomegaly prompts an offer for a fetal MR because we have found that as good as we are and as carefully as we look, there are some CNS abnormalities that are occult by ultrasound, detectable by MR. This is the kind of imaging obtainable now without any medication to mom or to fetus. There's no need for fetal paralysis. These T2-weighted sequences are really helpful, and what we found by doing MRs for what appears to be isolated mild ventriculomegaly by ultrasound is this, that other brain findings are demonstrated by in utero MR in about 10% of cases. The prognosis is influenced by those additional abnormalities. Most fetuses with isolated mild ventriculomegaly, isolated by ultrasound and MR, have normal outcome, but abnormal neurodevelopment is seen in about 10%. And that's really the last piece of information remaining, is really how do these kids do at school age. And we're still the first crop of fetuses in whom MR was routinely used are now of an age where we can see their longer-term outcomes. Moving on from ventriculomegaly to other CNS abnormalities, this is quite a recognizable condition, anencephaly, which is recognized as a symmetric absence of the cranium, a uniformly lethal fetal condition whenever it is recognized, also associated with elevated AFP levels. What can be a little bit confusing is that in some cases angiomatous stroma develops at the cephalic end of the fetus that might mimic abnormal brain, but there is no calvarium, symmetrically absent, and in that way different from amniotic band syndrome or microcephaly. Looking for other abnormalities at the level of the calvarium, here is 2 examples of cephaloceles, typically midline lesions, most often occipital. If they are skin covered, then the AFP might not be elevated. The prognosis for cephalocele is usually poor. It often has to do with how disordered the brain is, how much brain has herniated. There is a particular syndrome associated with a cephalocele, and I'll show you those associations. Here is the abnormal brain findings with a calvarial defect and herniated material, big echogenic kidneys with tiny cysts and polydactyly, and this constellation characteristic for Meckel-Gruber syndrome. One of the hardest things can be to distinguish a cephalocele from a cystic hygroma, so I want you to see them side by side. On your left is a cephalocele, and one of the most helpful observations is the acute angle it makes with the scalp, often a skull defect, and usually brain can herniate or not, but usually the brain is abnormal. Contrast that with a cystic hygroma on your right, an obtuse angle with the scalp, an intact calvarium, a normal brain, and usually a midline structure down the middle of that fluid-filled collection, the nuchal ligament. The posterior fossa is a required image and should be documented in every fetus. A normal vermis is shown on your left, and on your right, a fluid-filled structure in the midline due to the absence of a cerebellar vermis, indicating Dandy-Walker malformation. There is a range, it is a spectrum condition referred to as the Dandy-Walker malformation, may be associated with ventriculomegaly, often when it is only mild. And like the other entities we've discussed, the prognosis is influenced by associated malformations. I want to dwell a moment on agenesis of the corpus callosum, largely because of all the things I'm showing you, this one is really missable. The others are pretty obvious. This can be really subtle, and it matters. So it's the worst combination, something that matters and you want to diagnose in neuro, but it's hard to do. So I want to start with coronal pathology specimens of a normal brain on your left and one with agenesis of the corpus callosum. There's no corpus callosum on your right. You can see the characteristic configuration of the frontal horns of the ventricles and that high-riding midline cyst. So keep that in mind as we look at the fetal sonographic images. An important diagnosis with serious implications. 10 to 20% of fetuses with agenesis have abnormal chromosomes. Post-mortem, they are found to have a significant risk of other CNS abnormalities and non-CNS abnormalities, and a list of scary associated syndromes and conditions, which can be seen in the setting of agenesis of the corpus callosum. Now, if we could get this view in every fetus, it wouldn't be so hard. But we are not expected or can routinely document a normal corpus callosum in utero. It requires sort of a lucky chance of the transducer entering the fontanelle, in this case a midline sagittal view, and showing it. But that is not the basis on which the in utero diagnosis is based. Rather, we rely on indirect signs to make the diagnosis. Ventriculomegaly, usually mild, and most important, telltale configuration with colpocephaly, a teardrop configuration, narrower anteriorly and dilated posteriorly, and then an absent cavum. And it seems like that shouldn't be that hard, but I'll tell you that it's possible to mislead oneself. Rather than seeing the cavum as expected, you can see a fluid-filled structure there in the midline. These are coronal views. On your left is a normal appearance with the cavum filled in with red. And on your right, as tempted as you might be, you really are not seeing the cavum. Rather, these are steer horn configuration of the frontal horns and a fluid-filled midline cyst. And not to be misled by an image like this, lower left, that's not a cavum. There's a line down the middle. Those are the fornices. And I think on that, therein lies the risk of settling for a picture you think is probably the cavum and not realizing it's really absent. This is a constellation of the necessary findings to make a diagnosis of agenesis: mild ventriculomegaly, colpocephaly, no cavum, but I'll tell you, this is another instance where MR is really helpful. As hard as we try to make the diagnosis, MR can make it pretty easy. So the cases in which we are sure or highly suspect it, we confirm with MR. Coming back to the cavum for one last comment, when the cavum is not seen, but a corpus callosum is at least partially present, as is the case here, in a coronal and axial view, a condition to consider is septo-optic dysplasia, which would be important in terms of counseling and postnatal evaluation. Now, I want to talk about choroid plexus cysts largely because they are so much more common and really not much cause for concern, and we all play a part in how much concern is triggered among patients when this observation is made. This small cyst within the choroid of the developing brain resolves typically on its own and is not in and of itself a structural abnormality. It's almost a normal variant. They can be quite big, they can be multiple, they can be bilateral. The reason they're in the literature, the reason they've created such a stir is there is an association with trisomy 18. This is the association. CP cysts are seen in about 50% of trisomy 18 fetuses, but they are seen in 1 to 5% of normals. And you do the numbers, many, many more of the cases that we see are normal fetuses, inconsequential finding, rather than trisomy 18 fetuses. So if it's an isolated observation with normal screening tests and an otherwise normal ultrasound, that is a low-risk patient. Helpful to us is the fact that trisomy 18 are typically dysmorphic and dramatically so. CP cyst wouldn't be the only observation. 75% are identifiable by ultrasound and have a host of abnormalities, including other CNS findings and heart findings, and the telltale hand finding with overlapping digits. So this is our suggestion for the workup of choroid plexus cysts seen in utero. Look really carefully to see if it's isolated or if there are other findings. What we recommend: an isolated observation with a low-risk patient based on screening tests. No further evaluation is recommended. Depending on how and where that ultrasound was done, we might prompt a sort of additional targeted survey, and I'll talk about what we target. You don't need to do more ultrasounds to reevaluate this, and we don't prompt an amniocentesis. If we're targeting additional views because a CP cyst was seen, what we want to make careful observations about are the heart, and in particular, an open hand. And this verbiage is in your syllabus. I won't read it here, but I'll tell you we came to some consensus within our lab about how we're going to describe the observation of choroid plexus cysts, recognizing it can be associated with risks, but dialing down the level of suspicion if seen in an isolated way in a low-risk patient, not prompting further anxiety or workup. And in my last 2 minutes, I get to talk about short limb bone dysplasias. I'm only going to focus on the two that are of this rare entity, the most common and the most recognizable distinctively. So you are familiar with, reminded of what to look for if the bones are exceedingly disproportionately short. The first is thanatophoric dysplasia, one of the lethal bony dysplasias. The limbs are severely shortened and, in this case, markedly bowed. The short ribs give rise to the pulmonary hypoplasia, thus the lethality. Remember that in these cases, there's normal mineralization and platyspondyly. When I was a resident, we learned about telephone receiver femur, but I would venture to guess none of the current residents in the room know what I'm talking about. This is a telephone receiver of old. And that shape is the shape of the femur with the marked bowing and the widening at the two ends. Platyspondyly is recognized by ultrasound in this way. On your left is normal, with the spacing between the vertebrae about equal to the size of the ossification centers. On your right, platyspondyly, the ossified areas are much smaller than the spaces in between. And here is the severe rib shortening. The ribs come round to significantly less than half of the thorax circumference. And the other lethal type, recognizable and lethal type of bone dysplasia is osteogenesis imperfecta lethalis, which is type 2, markedly short femurs again. In this instance, you recognize this condition by the telltale appearance of in utero fractures, usually multiple and in unusual bones, and also these bones are demineralized. How is that manifest? Here is a wrinkled femur with multiple fractures of different ages and the postnatal correlate with X-ray. Here are rib fractures. Targeted views of the ribs are really helpful to make this observation, and the postnatal X-ray correlate. And the severe demineralization, which allows for the upside ventricle to be seen, which I said at the outset is not expected. So such good visualization is a clue to demineralized calvarium. And this chart, which you have in your syllabus, shows the side-by-side comparison of these two entities. In particular, there's a difference in recurrence risk and a difference in how their future pregnancies are working.